welcome to the Joint Commission Resources Quality and Safety Network. My name is Denise Katarabik, and I'll be your host for this program. Today's topic, medication management, is a complex process that involves multiple disciplines working together in the healthcare organization to ensure that medications are acquired, stored, ordered, prepared, dispensed, administered, and disposed of safely. Given the multidisciplinary nature and complexity of the medication management process, it should come as no surprise that medication management standards and elements of performance come up year after year among the most cited clinical standards across Joint Commission hospital surveys. Among the more problematic standards and EPs in recent years are those related to complex orders, which includes titration orders. Our program today will consider strategies for compliance with the most challenging medication management standards that are related to complex orders. Additionally, we'll take a closer look at issues related to titration orders by paying a visit to our featured case study organization in Philadelphia, Pennsylvania, Campbell University Health System. Helping us do all of that today is our distinguished faculty. Jeannell Mansur is Principal Consultant for Medication Management and Safety for both Joint Commission Resources and Joint Commission International. In this role, Jeannell provides direction to hospital leaders on medication safety design, medication system optimization, and technology implementation to support patient safety and effectiveness. Jeannell, thank you for joining us today.
Thanks so much, Denise.
Joining us during the case study chapter of our program will be Robert Campbell. Robert is Clinical Director of the Standards Interpretation Group at the Joint Commission. He also serves as the Director of Medication Management for the Joint Commission Enterprise. And as you'll see a little later, Robert is also a surveyor for the Joint Commission in the Hospital Accreditation and Critical Access Hospital Accreditation programs. And he is a reviewer in the Medication Compounding Certification Program, where he assesses compliance with accreditation and certification program standards. Before we begin our discussion, please don't forget that background information on today's topic and our faculty can be found in the resource guide for today's program. The guide also contains 2021 clarifications to the Joint Commission's expectations for implementing medication titration orders and sample forms to assist you with policy development and survey preparation. We'll begin today's program by identifying the top issues related to complex orders, with the emphasis being on titration. Additionally, we'll discuss strategies for compliance with the most challenging medication management standards related to these complex orders. Collectively, these standards address the ordering, implementation, and documentation of complex orders, including titration. We'll start with MM 060101 EP3, which requires that the administration of medication follow the prescriber's order. It was the top scored medication management standard in the time frame between January 2020 and September of 2021. Fully 49% of hospitals surveyed during that time frame were scored as non-compliant. Jeannell, why is this so problematic for so many organizations?
Well, a big portion of the findings that lead to the scoring of noncompliance for that particular standard really have to do with titration, but not all of them. And titration orders need to be followed as they are written. And so what a lot of hospitals are recognizing is that the way that titration orders were developed may not be aligned with how titration medications are actually being given. So I think that is the main reason why this finding occurs so frequently during survey, is because we've got what I call first-generation titration orders. Just a few years ago, hospitals spent a lot of time developing drug-specific titration orders to include every required field that needs to be part of a titration order, but they made them very tight. They made them very restrictive. And when you're working with complex patients and complex medications that need to be titrated, you need to really balance the order and allow some flexibility.
The second most scored medication management standard during the time frame just mentioned is MM050101 EP11. This element of performance requires that issues related to medication orders be resolved prior to dispensing. 24% of hospitals were cited for noncompliance. Jeannell, what have you seen when consulting with hospitals on this?
I work with a lot of organizations to help them with titration orders, and we really approach it in several different ways to improve compliance. One is we do have them look at their existing titration orders and involve stakeholders, intensivists, critical care nurses, critical care pharmacists, as well as IT people, to see whether those orders are aligned with actual ways that those medications are given. And then the discussion begins about, well, what changes do we need to make in the order? And in the upcoming clips, you're going to hear about the use of range orders, which I believe is a key strategy for really allowing flexibility within those orders that's really needed to make sure the nurse can continue to follow that order and adequately manage the patient. So that's one strategy that we use, is really going back and re-looking at the orders that have been built and seeing whether we are compliant with those orders as we manage our patients, or whether we need to make adjustments such as what I've just described. But the Joint Commission has actually taken great steps to try to understand the complexity of titration orders and to modify its procedures to be able to support caregivers who are managing patients on these complex medications. I call these the allowances that the Joint Commission published in its June 2020 perspectives. And in that issue, the Joint Commission really published some changes in how they would look at titration orders.
What do organizations find challenging about this, and why?
Well, this is kind of a change in surveying. When surveyors in the past have seen problems with medication orders, they might have scored it at another standard that really spoke to the creation of medication orders. But in the last couple of years, there's been more scoring of problematic orders at this particular standard, which really speaks to the pharmacist's review of the medication order. And the reason why is our surveyors are saying, pharmacists have been required to review medication orders for many, many years. Why are they not catching these things? So the emphasis is being placed on the review, and this particular element of performance really speaks to the correction of problems that are seen within the order. Now, I have to say they're not all related to complex orders, but here are some of the things that I've seen. Either when a titration order is being created, perhaps the endpoint may not be an objective endpoint, and that really needs to be clarified. For example, if a fentanyl titration is being ordered for pain, well, what level of pain? And does everyone know the specific level of pain that is being targeted? Likewise, what I've also seen is sometimes we have two separate titration orders, both being administered for sedation of the patient, which is measured by a RASS score. And in one order, you'll see one RASS score, and in another order, you'll see a different RASS score. So these need to be caught during order review by the pharmacist. And when those types of problems are identified and that order has been reviewed by the pharmacist, this is where it's being scored. Now, I think another area that will have scoring at this particular standard will be for PRN medications where there might be two medications ordered on an as-needed basis without clarification of when to use one versus the other. We call that therapeutic duplication, and our surveyors will find that, I call it low-hanging fruit. They see it in post-op orders, they see it for multiple pain medications, multiple medications for nausea and vomiting, multiple medications for constipation. And when we don't see that clarity, that really provides the direction to the nurses to give one versus the others that's scored at that particular standard, and it's scored as really a failure to resolve that issue by the pharmacist during order review.
What are some best practices and effective strategies to be in compliance with this element of performance?
I think a primary strategy is really to look at how order sets are created and to build them so that you delineate if you've got more than one pain medication order, this medication is given for mild pain, this medication will be given for moderate pain, and this medication will be given for severe pain. Or if you've got a couple of orders for a treatment of nausea and vomiting, this may be your first choice order, and if this order does not relieve symptoms, then this would be your second choice order. When you can build those into the order sets, then it supports good prescribing where those are delineated. But secondly, we really need to emphasize to pharmacists that they do need to address these orders. They do need to contact the provider if they see this type of lack of clarity to be able to resolve it.
We're going to address two more medication management standards related to complex orders before we visit our featured case study organization and conduct a few mock surveys. This next one is MM040101 EP2, which requires the hospital to follow its written policy defining minimal elements of a medication order, including medication titration orders. Jeannell, 15% of hospitals are non-compliant with this requirement. Why?
Well, the Joint Commission requires for specific medication order types, and titration orders is one of those types, that if those order types are used in the hospital has to have a policy that states what the required elements are. So the first thing the surveyor will look for is a policy, and if they don't find a policy, then that's an opportunity to score at that particular standard and element of performance. Just recently, in January of 2021, the Joint Commission included in its standards what the minimum required elements for titration orders are. Usually it lets organizations develop their own requirements, and it will survey to those. But in this particular instance, the Joint Commission placed in the standards, these are what we consider to be the minimum elements for titration orders. So if they see a policy that doesn't include those required elements, they will also score it there as well.
What kind of recommendations do you have for hospitals regarding this?
Well, do an inventory of your policies. Make sure that your policies delineate required elements in them, and specific to titration orders, make sure that all of those required elements that the Joint Commission put in the standards, such as starting dose, maximum dose, the amount of dose that you can increase or decrease at one time, and the frequency by which you can do changes, as well as a physiologic or objective endpoint. Those are the minimum required elements stated by the Joint Commission, and those need to be in your policy.
Thank you for that. The last medication management standard that addresses complex orders that we're going to talk about is MM050101 Element of Performance 4, which addresses the hospital's requirement to review medication orders for all required elements. Jeannell, where do hospitals that get cited for this tend to struggle?
I think seeing that the review process is not complete and really doesn't include all the required areas of review that would be expected by the pharmacist in reviewing medication orders. So it might be scored when perhaps pharmacists are only looking at certain aspects of the medication order, maybe whether they see an alert for a drug-drug interaction or a drug-food interaction, but not looking at whether the dose is appropriate for that particular patient based on renal function or other considerations. I think it is going to be scored when the surveyor believes that the review process itself is not as robust as it needs to be.
What kind of recommendations do you have for hospitals struggling with this?
Really, I think we need to look at what's being reviewed, what's being caught, what's not being addressed, and really trying to determine why that is. This is such a fundamental part of review that if this is scored, it really begs the question of what did they find and why was it happening? And I think that it may be a training issue, it may be a setting expectations issue, but it's certainly something that pharmacy leadership needs to, I think, dig into and really find out what specifically is occurring and why.
We'll be spending the rest of today's program showing you 3 pre-recorded videos illustrating how these requirements are surveyed, and then ask Jeannell to comment on each. Collectively, you'll see how the ordering, implementation, and documentation of complex orders, including titration, is assessed during a survey of your organization. We sent our second faculty member, Robert Campbell, and a video crew to our featured case study organization, Temple University Hospital, a part of the Temple Health System. The first video we are going to show you involves a patient on titration orders related to being a kidney donor. Let's take a look.
All right, good afternoon, Darlette.
Good afternoon.
Hi, so today what we're going to do is take a look at one of your patients that you're taking care of and look at how the medications are administered. If you want to give me a brief background on why this patient's here.
Sure. So this patient's here donating his kidney.
All right. And is he on any titrated medications?
Yes, he's on a few different titratable meds.
Okay. So let's take a look at those. So if we could take a look at the first one you got there.
Okay. And that's the Precedex.
Okay. And if we can look at the order.
Okay.
So you have an initial infusion rate, initial dose there. Okay. And it's 0.2 to 0.4 micrograms per kilogram per hour. And then you can increase that by how much?
By 0.1 to 0.2 mics per kg per hour every 30 minutes.
It looks like this patient has an initial dose of 0.2 to 0.4 micrograms per kilogram per hour.
Yes.
So how do you determine, Darlette, what dose you're going to start at inside that range?
So we would start it off at the lower dose. However, if the patient's condition warrants, we can go up to like the higher dose.
Okay, and that's in your policy where you can look at that and see that. Okay, yes. Good. Same thing with the range I see there. When you increase it, there's a range you can increase. Is the same methodology used for that as well?
Yes, it is.
Okay, all right. So let's take a look here. It looks like we have we had any dose changes recently on the Precedex?
I have not.
Okay. Good.
Because he's within the target.
Doing good. Perfect. And how do you know what the target RAS is for this patient?
So the target RAS is actually on our storyboard. So target RAS is 0 to -1.
Okay. Good. What other medications is being titrated on this patient?
He is also on a fentanyl drip.
Okay. And what are we using that for?
That's for a pain level of less than or equal to 3.
Okay. And same thing here with the ranges, which is perfectly fine. That's within the Joint Commission requirements and your policy. So have you made any changes on his fentanyl drip in the titration?
No, not today. He's actually within the goal.
This is a good patient for you. All right. And is there anything else being titrated?
So he's actually on a phenylephrine drip.
Okay. All right. And have you had to make any changes on the phenylephrine drip?
I have. Actually, it had been stopped and I had to restart it.
Okay. So it was a paused medication because why was it stopped? Did he not need it anymore?
It was, yes. So at that time, his blood pressure, his MAPs were greater than 65.
Okay.
And the order is to maintain MAPs greater than 65.
Okay.
They had stopped it, but then about an hour or so later, his MAPS dropped to like 60, blood pressure dropped, so I had to restart it.
And how did you go about restarting that medication?
I actually just restarted it at the lower dose, and the previous dose also. So he was at 25 mics, and I just restarted back at the 25 mics.
Okay. Is that how your policy works? You just restarted at the last dose?
Yes, but if his blood pressure weren't to goal, I would start at a higher dose.
Okay.
If it warrants the
Okay.
the higher dose.
All right. And then, so you restarted it, and then what's your policy for how often you have to assess the patient?
As far as blood pressure, so I mean, we do blood pressures every hour. However, if I'm titrating a medication, I would do it a little bit more frequently.
Okay. All right. And then you could make changes if you needed
Yes.
to based on
So
that.
based on this order, it's every 3 to 5 minutes. I can titrate the medication up.
Okay. All right. Do you have any questions for me?
No.
All right. Thank you so much.
Oh, you're welcome.
Jeannell, what struck you the most about what we just watched?
I could already see that several things have been put in place. I appreciated, as the nurse was telling Dr. Campbell about the different titration medications and how they were ordered, that the organization had included the use of range orders. She was discussing the use of a range for the starting dose, and Dr. Campbell was asking how she determined how she would approach that range, and she referred back to the policy. So not only had the organization really incorporated ranges in the starting dose and in dosing adjustments as well, but it seemed as if they were really creating an approach to how to go through that range or select the starting dose and placing that in the hospital policy. So that certainly showed me that work had been done already on this.
Yes, we'll talk a little bit about the work that they did during our third visit, where we'll present a system tracer. But before we do that, let's see one more patient tracer. Here, Robert is going to interview a nurse about titration orders related to a patient who is a victim of stabbing.
So good afternoon, Patrick. We're going to take a look at one of your patients that's on titrated medications. If you could quickly give me a quick history of why this patient's here.
Yes, sir. This patient came in for a stab wound to the abdomen. They went from the emergency department to the operating room where they had multiple procedures, procedure on the duodenum and an arterial procedure. They were then sent up to the ICU.
All right. And are they on any titrated medications?
Yes, sir.
Okay.
Multiple medications for sedation and pain. Patient is on fentanyl and propofol.
Okay. So let's take a look first at the propofol order here. So it appears you have a starting dose and you have an increased or decreased dose. You have the frequency for it. And then your goal here, so the goal is to maintain specific RAS goal. And then over on the side, if you want to talk about this for a second, this target arousal level RAS.
Yes, the target arousal level RAS is a -1 to a -2. That is our sedation level.
Okay.
We have documentation, and based off of what we are allowed to do with our license, our clinical judgment determines that level.
Okay. And so your organization has chosen to put the target RAS as a different order in the chart versus having it part of the medication orders.
Yes, sir.
And that's fine to do. Good. So we have propofol. It looks like you've started that. And have you had to change that dose yet?
No, sir. So the patient was on propofol in the operating room. Based off the procedure, you would want them to be sedated. When they came up from the operating room, we initiated the propofol at what the dose was down in the operating room. So it's a new order for the ICU, but same dose.
I got it. And then let's look at the other medication they're on that's being titrated.
Yes, sir. Fentanyl.
Okay. And again, we have a starting dose. Your starting dose has a range of 25 to 50 mics.
Yes, sir.
And then how do you decide where to start them on?
Where to start the fentanyl?
Yes.
So with this patient here, the fentanyl was started at 50 because this is what the patient came up on, was at 50. And as far as other patients or every patient that is on fentanyl, we have guidelines, hospital policies based off of what we're allowed to do with our nursing licenses to determine where we start.
So in this particular case, you have both fentanyl and propofol for sedation.
Yes, sir.
So can you talk to me a little bit about, did you receive any special training or education, or how is it so that you can pick which one to give, or how do you know which one to give?
Yes, sir. So also through our health system, we were given specific education, both computer and practical, to determine which medication we would titrate up and down based off of sedation and pain level. They also gave us guidelines which we can click into through our computer system right here.
Good. All right, and since there was a change here, talk to me a little about why you made that change.
Yes, sir. So I increased the fentanyl from 50 to 75 because the patient became agitated. So the RAS score was different from the goal.
Okay.
Also, the reason I did fentanyl instead of propofol was because of the other symptoms that the patient was showing were pain-related more than sedation-related.
Okay. All right. Good. All right. Thank you.
Yes, sir.
Jeannell, let's hear your reaction to what we just showed our viewers.
Well, that was an interesting segment. There were a lot of things to really appreciate in that segment. The nurse was talking about, again, we had a patient with a starting dose and a range, and I think there was some very thoughtful discussion about how nurses make decisions about where they will start within a starting dose range. This particular nurse referenced nursing licensure limitations, and that may be specific to what is required in the state of Pennsylvania, but I thought that was interesting because they were aligning nursing licensure requirements with their policies to allow a little bit more judgment on the part of nurses as they were making decisions about where in the range the nurse would select. That was one thing that was very interesting, and I found the discussion about the physician order, which is going to state what the RAS score is for sedation. This was a patient where more than one medication was being used for sedation. And when Dr. Campbell asked about the RAS score, they noted that that was a separate order by the provider to place the RAS score that would pertain to both of those orders. So it eliminates the problem that I had mentioned earlier about two different orders, both for sedation, but they each have different RAS scores. And so this is, really setting a goal for a certain level of sedation, and that will guide the nurse through administration of multiple drugs for sedation.
During our last visit to Temple University Hospital, we are going to present a system tracer. We'll hear about some of the performance improvement activities that Temple University Hospital undertook after their last survey.
So I understand in talking with your staff on the floor and your leadership that you've done quite a bit of work related to titrated medications. So how did your organization determine the need to work on this topic?
So back in 2019, we had the Joint Commission come give us a site visit, and we identified some issues related to titration at that time. Where we were non-compliant in some of our ICUs related to titration. So we put together a team of individuals from pharmacy, nursing, our regulatory partners, and actually partnered with another facility in the city that was also experiencing some issues related to titration to kind of come up with a plan of how we can execute and make it easier for us to be compliant when it comes to the titration guidelines that were put out by the Joint Commission, and also within the scope still of the nursing practice.
So as Joe alluded to, back in December 19th, after we had our survey, when we identified our issues, really what we kind of decided to do was take our team and really find out a way to marry how we practice clinically and how we take care of our patients while also being compliant with the Joint Commission. And really, that was the goal of the whole thing, and that was the hope was that through policy and through education, we would be able to practice compliant through the Joint Commission, but also provide the best possible care to our patients.
I've heard a lot about this being triggered from your Joint Commission survey you had. So once we finished the survey and your organization had a chance to look at your performance in this area, how did you determine if it was a systemic issue or if these were one-off issues found during the survey process?
Yeah, it was clearly a systemic issue. It was how our policy was written. It was how our procedures were across the board, and so I think the Joint Commission review helped us to truly understand the nature of the issue and to give us an idea of what we needed to do to fix to be able to move forward to provide better care.
Good. So what processes did you take to determine what needed to change? So how did you decide if it was the orders that needed to change versus the policy that needed to be changed, or both?
So when Temple identified that there was this systemic issue, they went to the policy and examined the policy first to take a logical approach to breaking down the issue into actionable steps. After taking a look at the policy and understanding that the policy did need to change, it was time to contact the subject matter experts and really have them take a deep dive into what their processes were and how we could best articulate that in the policy and in the procedures so that clinicians could follow it.
Good. And so who did you determine to be the subject matter experts for this?
It was critical that we involve both nursing and pharmacy in this issue, as well as other stakeholders reviewed the policy after those subject matter experts really opined on the critical issues.
Pharmacy.
So as Bridget alluded to, when we really looked into our policy and we looked at our orders, we realized that both of them really needed to be altered or adjusted so that we could improve our compliance rates. Our policy wasn't very robust, wasn't very nurse-friendly, I'll say. And then our orders were very strict and weren't very realistic for actual patient care. So when we really took a step back, looked at how they were written, and looked at how we can effectively provide care, there was a big gap there. So, realizing that, we decided that both these need to be adjusted in terms of both the order and the policy.
So that's a great point. What I'd like to do now is I'd like to talk about how the medical staff began to review the orders, and then we can transition from that into nursing and how nursing worked with pharmacy and the medical staff to find a more nurse-friendly policy that would still support safe patient care. So how did the medical staff get engaged in this process to review the orders and determine what should be changed?
Yeah, and I'll take one step farther from it not being a nurse-friendly process in that it wasn't a nurse-friendly process, it wasn't a physician-friendly process, nor was it a patient-friendly process. And so we hit the trifecta.
Yeah.
And at that point, it becomes easy to decide to make a change. You want to do something that you don't have to call the physician every single time you're making a small change or an adjustment to it. And so what we really did was jumping off of what Carrie had said and what Joe had put together, brought it to the critical care committee, led by our physicians and our critical care docs, and really dove deep into the issues to figure out how do we create something that still meets the regulatory requirements, but at the same time allows the flexibility that's necessary to take care of patients in that real-time moment of care delivery.
Right. So let's transition now to a nursing component of this. And how did you engage frontline staff to get the voice of customer, if you will, from the bedside care providers in nursing in determining what becomes a nursing-friendly policy?
From very early on, when we were putting the teams together, we identified clinical staff at the bedside to be part of this process. And I think that was helpful in the development both of the policy, but also trying to make it realistic. When we're coming up with guidelines for titration, when we identified the ability to make range orders, is this feasible? How does this work within your workflow? If there's an emergent situation going on, can you really do this given the way our policy or orders are written? So having them part of the process very early on was instrumental in the way our policy looks today.
That's great. That's great, Joe. So how would you describe the buy-in from nursing related to that?
The buy-in, they welcomed it because I think, as we alluded here at the table, they were so restricted.
Right.
They were trying to abide by the physician's order, and it was so tight. They were walking really a tightrope on which way to go. And do I need an order? Do I not need an order? So with the ability of us adjusting the policy still within the scope of nursing and still with a little bit more autonomy, they were still able to practice and treat the patient without having to be interrupted every 3 or 4 minutes to get verification from a physician on what the next step should be.
That's great. That's great. The other thing I want to commend you on from the pharmacy perspective, there's a big misperception of the prohibition of double range orders. And I was very happy to see that you've instituted that, because it gives you much more flexibility. So, in our world of pharmacy, it's a very misunderstood thought that we don't allow range orders, when in fact we do allow range orders. It's up to your organization to allow them and implement them. So I applaud you on taking that step and really validating that was the right thing to do, because it does give you that flexibility. So congratulations on that piece. So you've now made changes to your policies, and you've made changes to your physician orders and order sets. How did you provide education to the staff? So not just nursing, but pharmacy staff as well as the medical staff on all of these changes?
Sure. The policy process allows for education to start right at the very beginning. When a policy is decided upon, first it'll go through a local committee set. So in this example, it would be critical care. That committee would take a look at the policy and comment, and the P&T committee as well on the pharmacy side, taking a look at the policy, commenting, having the ability to influence the policy, and the education starts there. It also goes through a more formal process with our patient safety committee, and that allows other voices and other people to learn about the policy and bring that back to their areas. And then from patient safety, it goes up to med staff. So all the physicians that are represented on med staff have the ability to offer input, but also to begin the education process. And that's how it really starts to get formally known. And then we would spread locally through a less formalized process in spreading it to the different teams through their leaders.
Good. So let's talk about nursing, Joe. How did you provide the education to the nursing staff so they would understand the changes that were made?
As we alluded to early on, we brought in bedside staff from the very beginning on this, because we knew this was going to impact their workflow and what they were going to be doing at the bedside. So having their input not only on what the policy would look like, but also how, again, that's going to affect their workflow and what they were doing. There were 2 components of the education that we rolled out since we've revamped this policy. One was the titration components of it, with the addition of range orders and multimodal therapy, some things that we've added to the policy. And then block charting was another big component that we added to our policy. The block charting took a little bit more of at the elbows type training to kind of let them know what would be an event that would be that would happen on the floor that would constitute block charting versus a code. And so that took a little bit more training to kind of let them know this is the scenario when block charting would be useful. In terms of the titration component of it, fortunately all our orders were written with the ranges and everything that are comprised of what a medication administration order should look like. So that was just the education surrounding that. Now you can give a medication in this amount of time period, and you can increase the dose this amount of time. That changes were coming because every medication in our medication arsenal was somehow altered. So it was essentially just, we changed the IV titration guidelines. Please take a look at that. We focus on certain things that we know we used a lot of our vasopressors, because those are the things that we really adjusted the dosage as well as the time frame in terms of the range orders. So, and then we kind of continue that process throughout, even with new hires that come to the ICU, because they may be unfamiliar with the policy to begin with. So the education is continuous and ongoing.
So pharmacy education was another crucial point or crucial part of getting the word out there on our changes to our orders and to the policy. It was a really important one just because it was a new thing for our department. Double range orders in particular were a big question mark originally that a lot of our pharmacists felt in the past. We haven't used these, so they felt a little bit uncomfortable. We tried to get the word out there that we were working directly with the Joint Commission, and we were working together to both ensure that we're compliant as well as improve the care we deliver to patients. So the education, we started with email blasts and then followed that up with department meetings where we could meet kind of more so verbally and face to face and kind of discuss policy, discuss issues that pharmacists had, and try to make sure everyone was educated and ready for the changeover.
and the medical staff?
The education of physicians and APPs and others are always an interesting part of all of this. And what I found with physicians is there's a little bit of the WIFM philosophy, what's in it for me, but there's a lot of what's in it for patients. And so we always have to start with the why when we're educating physicians, because we're that breed of individual that we're not comfortable with change. It takes a while for us to warm up to it, especially if it's coming from perceived outside and somebody asking us to do something different. And so we always incorporate that into the education. And this in particular is why go double range? What's the benefit? How does it help? And so we come up with some concrete examples of where it makes an incredible difference, both to the physician and to the patient and to the others in the arena here. And then there is the organized education process. So this started with the critical care committee, and the physician leaders of the critical care committee took the lead on education and really disseminating it out to their sections and departments and beyond. It goes to the PI, patient safety committees. They have conversations about it, which then makes a bigger range of physicians that are involved. And then the Med Staff Executive Committee, which consists of all of the chairs and the elected officers of the medical staff, who then become the proponents for change. After that, we push it out in as many different venues and forums as we can, from department meetings and staff meetings and email and verbal communication and signage on the floors and all of those. And so it really becomes a comprehensive effort, knowing that somewhere along the way, someone's going to inevitably ask the question on Go Live Day, what's this? And so we make sure that the nurses and the pharmacists and others are also ready to help continue the education process to support each other, but then also to support the physicians. And in the end, everybody is geared towards supporting the patient.
Very good, very good. So how are you monitoring the outcomes of your change? And did that monitoring lead you to have to make any additional changes to the process?
That's a great question. One of the main things we wanted to look at when we were monitoring after the change was to make sure we didn't make any inadvertent or identify any inadvertent issues or uncover any inadvertent issues with the change. One of the primary things, or one of the things we did find out when we did start to monitor was we needed to make a little bit of an adjustments to our initial ranges or our initial rates for our continuous infusions, particularly as it related to patients that were transferring from either the operating room or the emergency department, or even from an outside hospital. So what we really did there was, again, kind of incorporated some range orders into our initial rates, and then also specifically addressed it within our policy in a particular section that is specific for patients who are coming from the OR or the ED or from an outside hospital, just so those issues can be, all nurses can be practicing congruently, and also we can avoid any potential issues related to compliance.
So within the ICUs, in terms of monitoring, we would do our own system tracers and do our own auditing to see how well we were compliant with the new policy revisions. And we still identified issues with titration. And so some of the changes that Kerry alluded to, making changes again within our dosage, some of it was just additional education to the staff, a little bit out of compliance with the range orders that we had. But one of the things that we uncovered more recently with our most recent change back in October of last year was our RAS score. And what we had found out, we had 2 different medications with 2 different RAS scores. So when we were doing our audits, we were finding, well, the nurses were compliant to this order, but non-compliant to this order. Yeah. So it was something that we didn't really expect when we were kind of doing our overhaul of all the orders. And so what we wound up doing was we took the RAS goal and also ICP goal, because they're kind of married together, we took them out of the pharmacy order and made that a physician order only. So now there's only one order for a RAS goal. And so now it actually, from a compliance standpoint, we made it very easy for our clinicians and our nursing staff to see what the target arousal level was from the physician standpoint in our EMR. So it was easy for them to flow within their flow sheet what the target arousal level goal was and what our target arousal level is currently, and then making adjustments to get to that achieved goal. So that was something that we actually just made a recent change on. We worked with our partners in our IT department to come up with an easy report to evaluate our compliance on that, and having some hands-on education with both the physicians and the nursing staff to ensure that the orders and the practice are congruent.
So what did you learn from the process that you could carry forward to other projects that you might work on?
Sure, that's a great question. One of the main things I think that I learned or was evident throughout this entire process is just that process improvement overall is really a continuous thing. And fixing one thing may lead you to need to fix another thing and may lead you to need to fix another thing. So it's not really a one and done thing. It's a continuous assessment and continuous improvement.
I think the single biggest thing that I learned in this and that we've taken away is that process improvement and safety begins at the proverbial sharp end of the spear. It's that frontline empowerment. It's getting your bedside nurses and physicians and pharmacists and clinicians actively engaged in the process to help improve our care delivery, to help improve the quality of care that we give to patients, and to help improve safety all around the organization.
I think one of the takeaways that we learned from, at least from the Department of Nursing, and I think kind of piggybacking on what Dr. Reed had said, was trying to get those end users, the bedside clinicians at the bedside, to the table when we were talking about these policy revisions and practice flow and how this was really going to impact them. I think by doing that, and when we did that, it made the rollout of this that much easier because there was already buy-in from the beginning, because it was not developed from the C-suite. It wasn't developed from a pharmacy committee or the ICU committee. No, it was actually developed in tangent with the bedside nurses. I think my takeaway is really making sure that you have representation from all the disciplines at the table when you're talking about changes like this.
And as an organization, Temple really appreciated the collegiality of the Joint Commission in this situation. This is new for us in using the standards interpretation group for further education, but we really benefited from it and our patients benefited from it. So thank you.
So thank you for that. I do have to say that the Joint Commission makes the Standards Interpretation Group available for our external customers, organizations like yourself, to assist with understanding what are the intent of our requirements and also debunking some of those myths like double range orders and things like that. And that's really what we're here for, is to help organizations be successful. So when it's time for survey, you can be ready, but not just that you're survey ready every day, which is the best care for your patients. I want to thank you all for taking the time to meet with me this morning. This was a great session. I was able to summarize some of the great stuff we saw on the floor today, tracing your patients, and I wish you all the best in the future. Thank you.
Thank you.
Thank you.
Jeannell, your comments, please, on this system tracer.
Well, I have to applaud this organization for being very, taking these steps early on. Granted, it was after their survey, but there are many hospitals that are addressing this right now, and it seems as if their work was several years ago. And that is not it's a considerable amount of work. But they have completed it, as they've mentioned. It's not always finished. They need to continue to monitor it and to make adjustments to continue to see the outcomes that they're looking for. But I appreciated that they were reviewing their policies and they were reviewing their orders and then involving key stakeholders, physicians, nurses, pharmacists, to provide input as to how orders need to change to be able to align practice with medication orders. And they had talked about really involving bedside clinicians early on to allow them to provide input before they finalized the policies and the order sets. And they recognize this actually as part of the education, is their involvement early on, but certainly I think it gave them good information as well to make good decisions about changes before they were finalized.
You mentioned that they were reviewing their policies and procedures and that you thought that was a best practice. Please elaborate.
Well, policies, policies will have owners. Every policy has a different owner, but it is smart to involve stakeholders who are affected by the policy. As I mentioned earlier, the Joint Commission's very specific about what needs to be included as required elements for titration orders. But with the allowances that the Joint Commission published in the June perspectives, this is also an opportunity for organizations to think about whether they want to take advantage of block charting or to take advantage of the Joint Commission's allowance for the administration of 2 medications for the same indication, and allowing nurses to use more clinical judgment to determine when one versus the other will be used. That's part of those allowances. Even the pausing feature, which one nurse spoke to in the patient tracer, is something that the Joint Commission recognizes as not being a discontinuation when you pause the titration, but rather often a normal part of carrying out titration orders. But that key question of when the patient is restarted on the medication, at what dose do we start them on, that may be something that could be included in a titration policy to provide direction for nurses when the patient needs to be restarted.
Who should be involved in these reviews? How often should they happen?
I mean, the first time a policy is constructed, I think, is an important time to involve all the stakeholders. When it's time to review a policy, whether it's every 3 years, every other year, or even yearly, depending on how often the organization has defined their review process. Often, you want to make sure that eyes from multiple disciplines review that policy and determine whether there's a need to update it and in what ways it needs to be updated. But, that can be a smaller group, but I certainly recommend that you have, for example, with a titration order, you have pharmacy, nursing, and provider eyes for especially those who work with titration orders.
As we near the end of our program, Jeannell, any parting thoughts for our audience that you would like to share?
Well, this is important work that needs to be done by many hospitals. It really does require relooking at orders and making revisions to orders if they're not aligned with actual clinical practice. I always say that, it's important to understand how well one is doing with titration orders. And sometimes the best way to answer that is to do your own tracers or audits and looking at patients who are actually on these orders, the changes that are being made in terms of dosing, what the parameters of the goals are at the time that change is being made, and to see if there is, a break between what is going on by the nurse and what the order is directing. So that at least gives you, I think, a feel for where you might be having problems. And it's important to drill down and to try to identify what the root causes of those problems are so that you can apply the solutions that are going to be directed at those root causes.
Jeannell, thank you so much for joining us today. We appreciate your work on this program and look forward to seeing you again soon.
You're very welcome, Denise. It's been a pleasure.
This concludes our program for today. All of us at JCR QSN hope that the information presented will help your efforts to improve and maintain compliance with the medication management standards. Along with Jeannell, I also want to thank Robert Campbell for his contributions to the design and development of this program, as well as his on-camera participation today. And finally, a very special thanks to the staff and leadership at Temple University Hospital and the Temple University Health System in Philadelphia for opening their doors to our production team and sharing their efforts and best practices with us. Until next time, I'm Denise Katarabik. Thanks for joining us and have a great day.